Okay, well, good afternoon, everybody, and welcome to the Johns Hopkins Alzheimer's Disease Research Center on Minority Age and Research Professional Development Series. We're so excited today to have our one of our scientists, RCMAR scientists, give a presentation of her results. We'll hear from Dr. Halima Amjad, but before we do that, I'm going to turn it over to Dr. Joe Gallo, one of her mentors, to provide an introduction. Joe?
Yes, I'm very pleased to do this. I get to work with Halima Amjad, and it's really great to be part of her team. She's an assistant professor in the School of Medicine and earned her MD and PhD from Drexel University. She was chief resident in internal medicine at Yale New Haven Hospital, and she came to Hopkins for a fellowship in geriatric medicine and gerontology, and then joined the faculty in 2016. Her research focuses on improving the care for older adults with dementia in primary care settings. And to that end, she was awarded a K23 Career Development Award from the National Institute on Aging on improving post-diagnosis dementia care in primary care. That's using mixed methods to understand barriers to post-diagnosis dementia care and to study an intervention to improve management in primary care. She also has an R03 that leverages the NHATS data to study health services consequences of undiagnosed dementia. And of course, since 2019, she's an AD-RCMAR scientist and is going to be talking about her work done in her pilot project, We're Walking Around Blindfolded, Diverse Caregiver Reflections on Dementia Diagnosis and Care. So I'm very pleased to have the opportunity to introduce her to you all.
Thank you, Dr. Gallo, for the kind introduction. And as Dr. Gallo sort of hinted at, my work has looked at undiagnosed dementia diagnosis and early care. And so this RCMAR pilot study was actually a perfect opportunity to really look at both of those elements together, looking at the diagnosis experience, challenges in diagnosis, as well as trying to better understand what caregivers need, especially early on when their loved one has had a new diagnosis of dementia. And of course, in this study, really focusing on diverse caregivers and really focusing specifically on minority populations. So I don't have too much background, and really I'd like to spend most of the time just sharing with you all what the caregivers shared with us. But in work that I and others have done previously, we know that half or even over half of older adults living with dementia, really globally, haven't been formally diagnosed with the condition. And multiple studies have shown that minority populations, in particular, Hispanic older adults and Black or African American older adults, experience most often higher rates of underdiagnosis. So there's multiple studies suggesting that they experience delayed diagnoses, even though those two populations, Hispanic older adults and African American and Black older adults, actually have greater incidence and prevalence of dementia. At the same time, in the literature and in clinical practice, risks versus benefits of screening and early detection of dementia are really not yet clear. And so the objectives of this study were really to explore, the diagnosis and challenges in diagnosis from the perspective of some of those populations that experience delayed diagnoses. And there has been work done on these topics in the past. I know, for example, I think one of my cohort scientist, Travonia, has done some work in this area as well. But I really wanted to look at this topic, one, from the perspective of a clinician who's working, as Dr. Gallo talked about, and thinking about how we can improve early care and diagnosis in primary care settings, which is where most dementia care takes place. And then also revisiting this topic because really in the last 10 to 20 years, I think public attention, government attention to dementia has changed. And so what people know or what people are expecting, I think, has changed. So the two primary aims of the study were one, to just understand diverse caregiver perspectives on dementia and how that contrasts to normal aging and their experiences with their loved one being diagnosed with dementia. And then also to identify benefits versus harms of a formal diagnosis of dementia, both perceived and actual experienced benefits and harms. And then also determining whether earlier diagnosis could potentially prevent adverse outcomes in these populations. And one objective that's not stated here, but that I would say for me was sort of a sub-objective, was again to think about or identify strategies or opportunities to improve early support after diagnosis in clinical care. So the methods that we used in this study, so it's a qualitative study, and actually the first qualitative study that I've led. In this study, we interviewed 18 family caregivers of older adults living with dementia. The breakdown ended up being 11 Black or African American caregivers, 4 Asian caregivers, and 3 Latino or Latina caregivers. You may be able to tell from the numbers, we had some challenges in recruiting the non-African American participants. We recruited our caregivers through prior research studies, specifically through the Mind at Home study run by one of my mentors, Dr. Quincy Samus. We also recruited through patients at the memory clinic, as well as through the Maryland chapter of the Alzheimer's Association, with interviews conducted from July 2019 to last summer, so just after the pandemic started. We did restrict to English speaking patients, so I think that's an important distinguishing feature, or just a caveat. The semi-structured qualitative interviews took about 45 to 90 minutes, and caregivers also completed a brief survey at the end of the interview. And topics that we discussed during the interview included how the person with dementia was diagnosed, as well as challenges that they experienced both before and after the diagnosis. We asked them, sort of details and what the process of diagnosis was like. We specifically asked caregivers if they would have done anything differently if their loved one had been diagnosed sooner. Then we also just asked them to provide us their understanding of dementia and Alzheimer's disease. And we did explicitly ask them about whether they thought that their race, ethnicity, or culture had any impact on, getting diagnosed and their experiences during the diagnosis process. Along with my research team, which includes Marcella Blinka, as well as a few students who've worked with us in the past, we applied conventional qualitative content analysis methods. And big picture, I would say really, I would say we didn't use pure kind of grounded theory methodology, but really we tried not to look too much at the prior literature and really focused on what the participants in our study were telling us. And we used those methods to develop a code book, ultimately code our data, and then analyze the coded data to identify themes. Right now, I would say we're at the point where we're actually writing up 2 different manuscripts. And I would say in that process, while we have our themes identified that I'll share with you today, certainly we're still thinking about how best to organize and present the information. As I shared, this was the first qualitative study I've led. And I think one thing I learned in the process is that there's just so much rich information that the caregivers and participants shared with us that it's a challenge to decide essentially what to publish or what to focus on, just because there is so much rich data. Now, just to give a brief description of the caregivers who ultimately participated. So as I said, there were 18 total. Their mean age was 62. They were mostly females, and I would say majority were actually daughters of the person with dementia. So most of the caregivers that participated were children, and the majority of the caregivers had a college level education or more. Their loved one with dementia had a mean age of 83 and actually had a little bit more of a spread of educational levels. And the caregivers had estimated a mean of 17 months from noticing symptoms of dementia to diagnosis. But there was a fairly wide range. So one caregiver said that within 2 weeks of really significant symptoms, they got to a neurologist and got diagnosed, to a maximum of 36 months or 3 years from noticing symptoms to diagnosis. Now, before I share the themes, I do want to share just some sort of, I don't know whether to call it miscellaneous results, but some of the results that I think relate to the aims of the study. So one piece that we found was that in really almost every single case, the family brought the symptoms up to the clinician, which was usually a primary care provider first, and usually unprompted. So not that the provider or PCP asked about the symptoms, but that the caregiver or family members brought it to their attention. We did ask both in the surveys and in the interviews how they assessed or felt about the timing of diagnosis. So we asked them if they felt like the timing was just right or if it was too early or too late. And about half of the caregivers felt the timing of the diagnosis was appropriate because a lot of them shared that, the symptoms were slow and it was gradual. And about half, the other half felt that the diagnosis was made late or too late. At the same time, most of the caregivers did not feel that they would have done anything differently had the diagnosis been made earlier. Specifically, one voice that comes to me is one caregiver who said, I want to say yes. When we asked, would you have done anything differently? She said, I want to say yes, but no, that they, somehow inside they feel that it would have made a difference, but in the end, at least from a practical standpoint, they wouldn't have done anything differently for their loved one. Now, when we did ask, especially the individuals who felt the diagnosis was made late, what they thought, what the benefits of an earlier diagnosis would have been, a few caregivers felt that they could have started medications for dementia sooner. And several caregivers felt that they would have known symptoms, impairments, or other challenges like safety challenges to monitor for. But overwhelmingly, naming the condition or simply understanding what was happening to their loved one was the primary sort of actual experienced benefit of diagnosis. And this has been seen in other studies before, including primarily qualitative studies. At the same time, I would say there was no significant harm both to the family or at least to the person with dementia. Again, sort of assessed, of course, by the caregiver because we're talking to the caregiver that was reported. If anything, when we asked if they thought that getting a diagnosis was harmful, their sense was that just, this wasn't the diagnosis that they wanted, but they didn't pursue sort of perceive true harm. In some ways, they simply just felt that it was harmful in the sense that they recognized that their future, so both as a caregiver and for their future of the person with dementia, was going to be different than planned. But nobody reported, I would say, truly, significant depression or anxiety. And as we see in clinical practice, I think most of the caregivers in the study felt that their loved one didn't seem to have full insight, or at least from what they could perceive, seem to really fully register the diagnosis and what it meant for them. And I did want to just touch on the role of, race, ethnicity, and culture for our participants since we did ask about it. Now, a few things that we found was that one was that most caregivers didn't feel that they experienced really overt racism or bias during the diagnosis process. But during our discussions, they did bring up a few interesting or I think relevant points. So I think in at least 2 interviews, the caregiver brought up the desire for either a culture or language congruent clinician that they felt they could have connected better, both in diagnosis as well as in care over time. Again, a few, again, a minority of the caregivers did note a cultural and language bias in testing. Now, I will say again, we focused on English speaking caregivers, and because the IRB did require, that we be able to at least attempt to assent or consent the person with dementia, even for us to just talk to the caregiver, since the caregiver was sort of talking about them. Because of that, again, even our patients all were at least to an extent English speaking. So I think that of course limits our ability to talk about cultural or language bias if everybody had some level of English language. There were differing perspectives on being together versus separated during the evaluation, but there were a few caregivers who noted that it was distressing and even perhaps more so for the caregiver to be separated during cognitive testing or during portions of the dementia evaluation, which, we sort of included it in that role of race or culture because some of that may be a cultural sort of a cultural feature that that a son or a care partner is with the patient during medical testing or medical visits. And a few caregivers did bring up the idea that they felt that there may be more difficulty accessing resources based on race and ethnicity, or differences in information that's shared differently by race. And in that area, I specifically am thinking about one caregiver who talked about, Alzheimer's conferences and how what they share or how they share it may differ in conferences that are for the general population versus at conferences that are at, she specifically brought up at a HBCU. And I thought that was relevant as well. So now I'd like to just talk about some of the specific themes that we found sort of across interviews. So the first was thinking about, kind of the pre-diagnosis challenges, potentially thinking about what challenges or adverse events were occurring before the person with dementia was diagnosed. And here for the kind of working name of the theme is it's not just memory. Memory was overwhelmingly what caregivers shared as the earliest symptoms, but there were also a lot of non-memory related symptoms that caregivers noticed before their loved one with dementia was diagnosed, and in some cases even before they noticed cognitive or memory symptoms. So specifically, caregivers brought up multiple different types of behavioral symptoms. Specifically, paranoia was common, as well as anxiety. They also noticed or had workup for what I termed physical symptoms. So significant weight loss, the person experiencing falls, or in a few cases, the person having episodes of delirium related to things like surgery, medications, um, for example. Some caregivers also shared that they had some safety challenges before diagnosis, with the person with dementia getting lost, for example, on their way home, having challenges in managing their medications or challenges in cooking. And caregivers also shared some of the stress that they or their family members, so non family members that aside from the person with dementia, experienced before the diagnosis was made. Some of that stress related to unexplained symptoms. Some of it related to their concerns about vulnerability to neighbors or other family members, as well as stress related to the fact that some of the caregivers were already unknowingly stepping into the caregiving role and starting to provide help, for example, with daily tasks or activities of daily living. And one representative quote I'll share with you really relates to, again, actually the fact that memory was the most common symptom. So this caregiver shared, talking about her mother who has dementia. I bought tickets to take her somewhere for her birthday, and I let her know ahead of time like normal. And the day came when I was supposed to take her, and I called her up. I got dressed and called her to let her know I was on my way to pick her up. And she was on a bus to Atlantic City. And this quote shows, both that there were some challenges in memory, though she wasn't diagnosed with dementia yet. And the quote actually had gone on to talk about how she was really hurt by this. And so, we were also looking at this as, is this that element of caregiver or family stress related to the undiagnosed condition, because the daughter didn't realize that her mother had a disease that was causing her to forget. It wasn't just that she was, blowing her daughter off when she had made special plans for her birthday. Another very common theme was just the idea of involving family really throughout the diagnosis and care process. So early on, as well as post-diagnosis, caregivers brought up the importance of listening to family concerns and family observations about the patient. They also brought up the importance of sharing patient information, as well as specifically sharing the diagnosis. So for one caregiver, the big challenge was that early on, her mother had told the doctor that she didn't want the doctor talking to them. That caregiver specifically shared with us that, I know personal information should be kept private. You have all these HIPAA rights and all that stuff. But still, I think when it comes to at least aged parents, they should make some sort of exception for family to help our parents. And in this case, the daughter really didn't have a chance to get involved until later on in the patient's disease course. A few caregivers also brought up the importance of recommending a family meeting or counseling so that the family could come together to provide care, and so that we could ensure that all family members understood the diagnosis and the condition that the patient had. And Caregivers also brought up the importance of understanding family and culture specific care plans. So specifically, a few African American caregivers brought up this concern or observation that clinicians tended to push nursing homes on them when that wasn't part of their plan, that their plan was to take care of their loved one at home. So in this quote, a caregiver shared, "He's a good doctor. The only thing is, for some reason, when patients get Alzheimer's, they want to just put them in a nursing home." Another theme that we found really, I think, across everything that, across all interviews was the idea that knowledge or information is power. So I shared earlier that cognitive screening is not, universally recommended in older adults, that the risks and benefits aren't clear of screening for cognitive impairment. But a few caregivers actually brought up spontaneously that they thought older adults should be screened for cognitive impairment and actually likened it to cancer screening, things like mammograms. And they felt that clinicians really should be proactively looking for early signs of dementia. And as I shared, in most cases, it was the family bringing it up to the clinicians, not the other way around. They also found, as I shared before, naming the condition to be really the primary benefit of diagnosis. And in this quote, a caregiver shared that she was talking with a family member and said, something's wrong with mom. You've got to find out what it is." So in this case, and again, we're talking to caregivers often years after the person's been living with the condition, that even though at this point they know that there's no cure, or really no effective treatment, that they had really felt that it was important to understand what was wrong and to be able to name what was happening and what they were seeing. Several caregivers also brought up the importance of having a roadmap, of knowing and sharing what to expect in terms of the disease course and helping to families understand potential challenges. Some of the challenges that came up were challenges with safety or financial vulnerability. And caregivers also brought up the importance of sharing concrete resources. Even if they didn't need it at the time, they felt that it was helpful to have as a reference for the future. There were a lot of really poignant quotes in this area, and I've shared a few here. So first is, "I just feel like in this universe, there needs to be a roadmap made for people to help the caregiver care for their loved one. There's not a roadmap to get there." And a lot of these same caregivers, I'll add, they recognize that the disease course is not the same for everyone, but even recognizing that, they felt like there needed to be some guidance or some roadmap. Another caregiver shared, "I just feel like this has been a flying blind assignment. We were flying blind even before we got diagnosed. The diagnosis was the crash landing, and now we're walking around wounded into progressively more dangerous territory." So again, this caregiver also felt that they were flying blind before the diagnosis, but even after the diagnosis, they're still walking around without much direction. Another idea that came across, really, I would say, through all the different types of participants, but particularly among our African American caregivers, was that nobody talks about dementia. And as I shared, while it came across in multiple different caregivers, including, Asian and Latino caregivers, among our African American caregivers, multiple caregivers actually shared that they only realized that other family members had had dementia after their loved one was diagnosed. That in the past, in other older adults or in prior generations, nobody talked about what the condition was. And overall, caregivers felt that now families, the public, and clinicians should be talking about cognitive impairment and dementia more openly. So one African American caregiver had gone into depth talking about how our culture is a secret society. And in talking about prior patients or prior generations, another African American caregiver shared that when people were going through Alzheimer's, they would hide them or send them away. So young people never had the exposure to it. Sorry, skipped ahead. Now, the last theme I'll share, and actually I would say it doesn't really relate exactly to the work I'm doing now, thinking about early care, or really even to, I would say our direct objectives, but it was just something that I know Marcella and I were both struck by as we were reading through the interviews. And it was just the theme that a lot of our caregivers really viewed caregiving as a privilege. And they talked about it even while sharing with us both past and present challenges that they had faced, that they still expressed gratitude about the opportunity to care for their loved one. One caregiver, one daughter shared, I just feel blessed that it happened when I'm here and I'm still able to take care of him. Another caregiver talked about feeling grateful that she had an opportunity to provide care. And particularly, we noticed among Hispanic and Asian caregivers that there was talk and discussion about having a culture of service or the sense of it's my turn. That, and I think the it's my turn quote came from a caregiver who was actually taking care of her aunt. But when she was younger and raising her own children while working, her aunt had helped to take care of her family. And so when her aunt started to have symptoms of dementia, she felt it was her turn to step in and provide care. Now, in terms of my reflections and conclusions, certainly we can talk more about, how the results I think are playing into the work I'm doing now. But I wanted to really focus on, I think, two quotes that have really stuck with me, and I think really highlight the importance of thinking about how we can improve diagnosis and really early support after the diagnosis for patients and families. So one daughter said, "I wish the doctors were a little bit more supportive. Not a little bit more, a lot more supportive after that diagnosis. They kind of leave the family out there, just hanging after they give them this major blow. That's almost like someone saying, 'You have cancer. Okay, you can leave now.' Well, what do we do? Am I going to get chemo? Am I going to need?" But look at the support they give to cancer. Doctors don't do that with Alzheimer's. And then actually building on the title of the presentation, and I think thinking about that caregiver who had talked about flying blind, this is actually sort of the rest of that quote. So I'd already shared how she talked about that it's been a flying blind assignment and the diagnosis was the crash landing. She went on to say, "And by the way, we're walking now in a minefield. We're walking around blindfolded and cut glass, littered minefield. And we're just dealing with the fact that we're hitting cut glass and getting our feet cut up. But there's mines if we don't deal with that. It's just a matter of time before we land on something, this major crisis." So for me, I'd say these last two quotes really highlighted the importance of really, I think, some of the themes that I've already shared. So the importance of that idea that knowledge and information is power, that clinically, a lot of physicians and other clinicians feel that, we don't have effective treatments. There's not much we can do, right? So one, I think, difference between cancer and dementia is that cancer, we have chemotherapies or we have, medications that have, moderate to significant effectiveness, and we don't have that in dementia. But just because we don't have that sort of medication or treatment to provide, that doesn't mean that there's nothing we can do, that there's nothing that our patient and family populations don't need. So I think for me, this really highlights that importance of being able to provide information, starting with the diagnosis and understanding what it means for the patient and family, both now and in the future, and really providing support to them, throughout the disease and thinking about, the fact that they're walking in a minefield. And actually, I'll share that, as I was reading this quote yesterday and today, as I was putting together the presentation, I was actually just thinking about a patient that I saw in follow up in the memory clinic this week, where they essentially had that major crisis, that they hit the minefield, that the patient had a few weeks ago wandered out of the house without shoes. And we all know it's very cold, and actually, thankfully, was brought back home, but has significant frostbite. And so for me, I would say that was sort of a wake up call of, what can we do better earlier? Now, sometimes despite counseling, providing that kind of proactive management, we can't prevent all of these outcomes. Um, but you wonder, if you start to pick up on, this might be a person who might wander, this might be a person who would fall prey to a financial scam. How can we make sure that we're providing that information to patients and caregivers, I would say before that event happens? So my last slide is just the acknowledgement slide, and I think the big acknowledgements for me are for the caregivers. As I shared, this was my first qualitative study, and if anything, I think my biggest challenge in looking at the data is, they shared so much with us, both directly related to our study objectives and beyond, and how do we honor what they've shared with us and really make it something that we can not just publish, but really act on. So for me, I'm really starting to think about, what the caregivers shared with us in terms of their challenges and what we could do to improve care, and really think about how can we turn that into changes in clinical practice or an intervention that can be implemented in the primary care setting. And of course, I want to acknowledge the funding from the RCMAR Center. The study wouldn't have happened, of course, without that support. And then, of course, my mentors more mentors than are listed here, but Joe Gallo and Quincy Samus have been the primary mentors here. And then Marcella Blinka, who's working with me both on analyzing the data and writing the paper. And then Sneha Gundavarpu was my MSTAR student, so a summer medical student last summer who helped us really code the data and is helping lead us on one manuscript that we're focusing on as clinician recommendations. So trying to come up with concrete sort of recommendations for clinicians who are seeing these diverse caregivers and patients in clinical practice. So I will pause there. I'm hoping for not just questions, but also discussion and thoughts. Like I said, I know others have done work in this space before. And I will say, at least for me, at least one specific question that I had was thoughts on, I think the other piece we've thought about but haven't acted on yet is how we can share some of these findings and results with the community. I think fine, we can publish clinician recommendations for clinicians, but I think, some of the themes that have emerged or what caregivers have shared with us, I think would be beneficial, for our minority communities as well to hear about, whether it's thinking about the idea that we should all be talking about and normalizing, dementia as another medical condition that's common, or educating communities about the fact that it's not just memory, that, here are some of, there's the warning signs about memory, but are there other changes that could be a sign of dementia?
Well, Halima, thank you so much. That was really an excellent and insightful presentation, and such important work. We have about 15 or 20 minutes for questions now, and I'm sure there are lots of things to discuss here, so I will go ahead and open up the floor. You can either just unmute yourself and ask the question directly, or if you want to put it in the chat window, we can read the question and go from there. So
okay, I have a question.
Go right ahead, Reba.
Thank you. So that was a very interesting presentation, and thank you very much. My question has to do with the opportunity for the caregivers and the family member with dementia to meet with other disciplines who can, like social work, occupational therapy, some of the other folks who can really provide a really good assessment of the strengths of the family unit and in how people are able to participate, the family house, where the individual lives, those different kinds of things that, and to also understand that, of course, with dementia, as with cancer, things change over time, but to allow people the opportunity to engage in what Barbara Resnick calls function-focused care. Barbara's a geriatric nurse professor at University of Maryland School of Nursing and former head of the American Geriatric Society and GSA, et cetera. And she has that. And I've also worked with an occupational therapy faculty member at Towson University, Kendra Shewall, who's actually giving a talk on this type of thing for the Baltimore City Health Department's caregiver conference this spring. So that's a long-winded question, a way of saying, what about the interdisciplinary approach on behalf of the family?
Yeah, well, So I would say I definitely agree that where possible, the interdisciplinary approach is ideal. I think one thing we didn't share, but of course we, our caregivers, some of the participants actually had previously participated in the Mind at Home study, which was a care coordination study. And so there, the participants did have some exposure to an interdisciplinary team. And at least a few of them, we didn't ask them about their experience in the program, but some of them did spontaneously bring up, the benefits of having that sort of team approach, and as well, referring to it as sort of wraparound care. The other piece is, I think, and something I've certainly been thinking about now in my work about thinking about, how we can improve or optimize care in primary care, is that several of the issues that were brought up by caregivers, I think, would be best addressed by an interdisciplinary team. So I, 100% agree that a family meeting or family counseling is important and ideal, but is a primary care physician, or even, myself in the memory clinic, are we the best people to be doing that versus, a care manager or a social worker or a psychologist? And, maybe we're able to, build upon that. We're the ones giving the actual diagnosis, but I think managing those dynamics, I think, would be best suited by someone who has, expertise in that area. And I think similarly, it wasn't a topic here, but I do think, and of course, as a geriatrician, I think it's really important to have some insight into the home, the environment, function, and that's best done at home. And really, again, by an interdisciplinary team. So having a physical therapist and occupational therapist go out, of course, would be important. I think, again, I think for us, the participants who had some exposure to that talk to it, I think the reality of our healthcare system is a lot of people don't have exposure to that. And so for them, the care they received and talked about was through the primary care physician and a specialist, who was most often a neurologist. So I think not nearly the ideal or optimal care that we all want.
Hi,
And
Halima. Oh, sorry, George.
oh, go ahead. I'm monitoring the chat box here, and Betsy Simon has written excellent, in my opinion, and for those I work with weekly, there is required need to share outcomes with first study participants as a group, then general community of populations represented, and of course, all others. So just a comment if you want to respond, Halima.
Yeah, and we did. I have to look through our list because we definitely did ask, most of, and I think most of our participants were interested in hearing the results. One thing I would be interested in actually in hearing about others who have more experience, I think, in sharing results with the community, is that decision of when to share results. I guess because, I've given a few presentations where, we're sort of still developing and organizing themes. In our case, we definitely do want to share results with the study participants. And we actually have one caregiver who works at Johns Hopkins, was going to participate, but then because of the pandemic, essentially we weren't able to organize that the people she was caring for lived in assisted living facility. We wouldn't be able to get assent or consent. And so she's someone too that we are involving, because we wanted to, ensure that before we're, publishing results or really disseminating, beyond our kind of smaller audiences, that they've, given their input or thoughts.
If I
Yeah.
could just say one thing, and that is having worked for 16 years in community-based participatory research, but more importantly, over the last 10 years, having worked with older adults in specific communities, one of the concerns and trust issues among people as minorities, and I'm sure everyone, is that studies are conducted and then the community that is represented is not aware of the results until they by chance hear it published or hear it on the news. So I know it's required to share the information, but I think until we do more of that, we're going to continue to have difficulty finding participants willing to participate in studies. And I just think that however it's done, and I know you say you need the experts in other fields, but the trust and relationship is often between the private, the primary physician. And so if there could be a collaboration among the groups and the physician remained a major part of that, that builds trust as well. But as for the results, I think I would hope it would become general practice that anytime you work with a group, you would share with the participants and definitely the populations they represented, because that is where a lot of distrust comes, that all you want is my information and my participation for your study.
Thank you. So we have another question, I believe. Cheney?
Yes, hi Halima, thank you for your presentation. I was going to piggyback off of the first comment, thinking about sort of this idea of the interdisciplinary care team. And going back to the comment that you made about the doctor sort of leaning in the direction of the nursing homes, I'm wondering if you got any insight from how often they might have leaned towards something like community-based services, or even if it's like durable medical equipment that could, be a piece of technology that's in the home. I was a care manager up in Connecticut before going back to school, and I don't recall receiving that many referrals from physicians. It was usually initiated by the family or the person who needed assistance in terms of receiving home care. And so I'm just trying to think about different ways that we could sort of address the fragmentation that we often see for community dwelling folks who could benefit from some of these services.
Yeah, and that's an excellent point. And actually, I meant to say too, I should have said this sooner. I know Marcella is here and obviously has been heavily involved in, analyzing data, thinking about the interview. So Marcella, certainly speak up as you feel comfortable. But I think just thinking through, I think big picture. So there wasn't a ton of people who talked about, community-based services that they'd used. Outside of the people who had participated in Mind at Home. So one, I think, of course, that's not what we were studying, but I think the use was likely low. And a lot of our participants had also talked about, I think, exactly what you were referring to, Cheney, was the fact that they had to go find these resources on their own. So, I sort of shared in the descriptor or the demographic slide, right? So our participants were, fairly well-educated caregivers. And so a lot of them talked about, going to the Alzheimer's Association on their own, finding conferences on their own, finding support groups. A few of them had actually set up or were now running support groups. But I think my general sense was this was happening a lot sort of on their own, not that they were directed to do these things or directed to these services by their doctors. And that's definitely, I think, a huge sort of gap, a gap in our system. And that's, I think, part of what the caregivers were mentioning was just having that information or knowledge. Of course, we can't expect doctors to know of every single service, but even if it is just, and I see that comment here too about, sharing the Alzheimer's Association, the hotline number, so that at least they know where to start, or at least, as some of the caregivers shared, that they just need to know about these resources for the future. So, often early on, impairments are mild, you're able to handle it, but as they get more challenging, do you know where to go? And I think that's something certainly that we need to work on and improve.
And I would just share that we did have a caregiver that when things started to get more than she could handle, she decided to put her mother in a nursing home. But she was still there every day with her. She was, part of everything of the decision making. So it wasn't that they will not do it. It's just not the first thing they wanted to discuss about how to handle the newly diagnosis.
Yeah, and I will say that's something, certainly that I think to an extent is probably cultural. So of course, when I'm seeing, patients, I'm coming from my own, cultural background. So I know I have a tendency more to ask, when the person has, when your father or when your mother needs more help, what what do you think that will look like? And some people will come out and say that, at a certain point we may need a facility. Others will talk about other family members bringing care into the home. So I think, Marcel, you can correct me if I'm wrong, I think there were maybe 2 caregivers whose loved one was now in a nursing home. So the majority were, community living. But I think the sense from, at least from what caregivers were sharing with us, it's not that they're opposed to it, but it's just they didn't want clinicians to just make that assumption. Rather wanted, clinicians to come from a point of understanding what would the family or the patient like to happen, and come that way, as opposed to, because there were a couple scenarios where the doctor sort of brought it up out of nowhere, that the person was there for something completely different, and an ER doctor said you should put him in a nursing home, and they were just, it was a completely off-putting, upsetting interaction for the caregiver.
Mm. So I was gonna just contribute to the discussion regarding dissemination. So recently, Joe and I were talking about research literacy, and it might be useful when presenting any sort of research results to just kind of have an understanding of how research literate the community is. So their understanding of what the methods are. And often I think when communicating with the community, it's good to figure out what they know, and to don't have to be really sophisticated or complicated in the methods, just to the point where they would understand and put into context the results that you have. I was thinking, for example, when you're looking at ethnic communities, sometimes it can kind of come off as stereotypes, just because it's not a quantitative study, it's not representational, the samples are small. I mean, even in quantitative studies too, when you're looking at means, it can also kind of come off as stereotyping and perpetuating those stereotypes. But if they can understand, what the methods are and how you arrived at these, and that it's not the limitations of the results, I think are also important to acknowledge too, because it could be that your audience may have experiences which don't really jive with your results. That's with any results in any study. And so they might, depending on the degree to which they understand the research methods, they might have a response that's not very receptive. So I think that's an important thing to consider.
I just have a comment. This is Marlon Taylor from the Alzheimer's Association. You made a good, first of all, the presentation was excellent. I thoroughly enjoyed it. As far as for when a patient is diagnosed with any type of cancer, the doctor normally recommends that that patient go to another, let's say, department or someplace within the medical field. And that's with any type of disease that, that has some type of curable aspect to it. But with Alzheimer's or dementia and things like that, that's outside of the medical field, if you will, as far as for the association. Do you think that may have something to do with why a lot of PCPs don't provide that type of information to their patients? It's outside of the medical field.
Yeah, no, I think you're right. I think it's, what we're sort of trained to do or comfortable with is putting referrals in to other doctors where, the referral's going directly to another doctor's office. We sort of know what to expect of what, in terms of what will happen, when the person goes there, what information we will be fed back. I think, when it comes to dementia, of course, a lot of referrals are placed to specialists. So, often the neurologist, of course, within Johns Hopkins to the memory clinic, which I would say is helpful to an extent. But I think, like you're bringing up, a lot of the issues or challenges are non-medical. And so even with those referrals, I don't know that all the caregiving or family needs, patient needs are being met. I think you dropped this in the comments here, and I know I've seen both at conferences and to a certain extent the rapid referral form. And I do think that type of form is something that physicians would be more comfortable with. That okay, it's sort of what we're used to. It's placing a referral. I think it's oftentimes knowing that service is available. Because actually, I know
Exactly.
even when the Alzheimer's Association rapid referral has been shared at geriatric conferences, not all of the geriatricians are aware, that that's available. So,
And
even within the community that knows some of the resources, we're not always, we're not always aware of it.
so that's, and you brought up an excellent point. That's something that we're working on trying, like with any community, this is the medical community that we're trying to reach to let them know, the services and programs that the association provides, even in this virtual format that we're in. So that's just another barrier that we're trying to break through, if you will. So if you have any suggestions, anyone on this live website, whatever, have any suggestion, please reach out to us and let us know how we can reach you and inform you. So,
and I think at least one challenge that we're thinking about in the primary care setting is, just the number or percentage of patients that any one primary care provider sees who has dementia.
mm-hmm.
That, while it's something that every primary care provider sees, the actual percentage of their total patient population, I think, is very small. So, we've been looking at some preliminary numbers and it's sort of in the single percentages.
Okay.
And so there, I think then one of the challenges is, if it was like blood pressure and they're seeing it all, hypertension, they're seeing it all the time, they would be more aware of the resources.
Mm-hmm.
So at least one, starting point that at least I can think of other people could add too would be at least, starting with the high yield clinicians, which may be even like, say, the community neurologists who are potentially seeing a bigger population of people with dementia who would benefit from having, that rapid referral or having a connection.
Okay.
Thanks, Marlene.
Thank you.
A couple comments here in the chat I wanted to be sure we get to. Betsy writes, excellent presentation. Also, it would be helpful if education starts before the study as a relationship begins to develop. I don't know if you wanted to comment on that, Halima.
No comment. I was just thanks for the, I think for the advice or suggestion.
Okay. And then Monka writes, great presentation. 2 comments. Some of the themes are similar to what we are finding with African immigrants in Minnesota. Also, in our work with memory clinics in Minnesota, we are finding that the care and assessment is very heterogeneous. And I'm curious about which providers would be the recipients of the recommendations you are all drafting.
So I would say, so there's the recommendations that we are drafting currently, I think that are, sort of directly out of the themes here. I think, it's something we're still working on. So actually, I'm glad you asked that question because that's something we should definitely think about as we're, writing up the manuscript. But really, it would be thinking about both primary care providers as well as, again, like quote unquote dementia specialists, because I think as you brought up, that even within the specialist, the care and assessment is very heterogeneous. Even for me, as I've read through interviews, I'm finding, holes or gaps in the care I'm providing to patients with dementia, thinking, am I providing anticipatory guidance about what to expect? And so I think those would be the main populations. And in the work I'm developing through my K award, that's very much focused on primary care providers and their capabilities. But I think what we've learned here, I think, is applicable to all, both specialists and primary care providers, and really because both are providing dementia care.
One thing I would add, I know because we're all, our majority of us, some of us are physicians.
Yeah, some, I think it's some.
Yeah, so, and sometimes I think there's a little too much emphasis on just the physician. Because I work in primary care and the integrated care setting, it's always interdisciplinary. And I know that I focus and work really, the social workers do so much. And then I've been working in the primary care and the memory clinic, which is a specialty clinic. And I know that the nurses do a lot of counseling, and really they're the ones for whom the social and the social service organizations, community organizations, the information, if it got to them, not really the physician so much, but that there is probably in these particular settings, in my experience, a better chance that the patients get that information. So the physician often is kind of narrowly medical. If they have time, then they may broaden their counseling. But generally, it's kind of division of labor, you know, in the experiences that I've had.
No, that's a great point. As I said, we're sort of still, you know, drafting and thinking. And so that's actually a helpful way to think about, you know, as we're looking at the recommendations, you know, some of them, would they apply more to, you know, other interdisciplinary team members, and thinking about how we can frame it that way, I think is important. So thank you for that comment.
And Betsy has added also the certified health education specialist you want to include. So we are just about out of time. Maybe there's time for one more quick question or comment if anyone has any.
This is Alicia. I just wanted to firstly congratulate you, Halima. What important work you're doing. And just to offer something that Quincy has recommended to me for our dissemination efforts is to maybe think about creating a kind of newsletter or something to share with participants in whatever way you're already communicating with them. So we are thinking about putting something like that together. And not only, you know, also to kind of member check it, so to speak, like, did we get it right? Is this what you're saying to us? And I just think that that might be an interesting way to disseminate. There may be other creative ways as well, but congratulations, really good, important work.
Well, thank you again, Halima, for just a really terrific presentation. And I want to thank everybody who attended the session today. I thought it was a great discussion. I wanted to remind you all that next month on March 12th, Friday, March 12th, Dr. Carl Hill from the Alzheimer's Association. He's the Chief Diversity, Equity, and Inclusion Officer for the Alzheimer's Association. And having moved there from the NIA, where he was the head of the Office of Special Populations at NIA and also headed the Butler Williams Scholars Program. Dr. Hill will be joining us for our Professional Development Seminar Series next month. And the title of his talk is Achieving Health Equity by Addressing Disparities in Alzheimer's and All of Dementia. So I'm really hoping that you can join us then. Roland, did you have anything else that you wanted to add?
Yeah,
before we close?
I just briefly want to say a big shout out to Joe, Quincy, and Marcella, the mentoring team that helped Halima along the way. We really appreciate all that you've done. This was outstanding, Halima.
It sure was. Well, thank you, everyone, and have a great weekend. Hope to see you next month.
Bye-bye.
Bye-bye.